Welcome to Aging Under the North Star, your trusted podcast for aging, caregiving, and senior living. I'm your host, Veronica Quinones, the founder of North Star Senior Advisors, and today I have Kristina Pedrazza. She is a social worker and also the director of case management. Thank you so much, Kristina, for joining us today.
Thank
And
you,
tell me a
Veronica.
little bit about your background and stuff. I've known you for so long, and you're a wealth of knowledge, and I just think that your skills, your background, your expertise, everything all aligned in one package can just be beneficial to some of our listeners and viewers.
Thank you, Veronica. Yes, thank you for having me. I've been a social worker for 14 years now. I've worked in and out of a hospital setting, mainly skilled nursing facility setting, and now I work in inpatient rehab.
What made you get into social work?
Oh, that's a very good question.
You're like, why? No, I'm just kidding.
Yeah. So
Just
I
kidding.
actually got my AA in elementary education. I wanted to be a teacher. Ever since I was a child, I wanted to be a teacher. And I was doing the part in college where you got to go and look at a classroom, sit in the classroom, observe. And then I realized I wanted something more than just a classroom setting. I wanted something greater and bigger. So I took time off and I finished my degree. So I got the AA. I took time off just to figure it out. And there were some personal things that guided me into social work. And I read some great books that led me to understanding social work more and knowing that there was a lot more than just one setting with social work. You can work with children, elderly, you can work in school settings, you can work in the community, you can work with homeless populations. So much stuff. It was so broad, and that's what I loved about it.
This is very important to me, this topic, because my profession, I'm working a lot with the geriatric population, and usually they're coming out of a skilled facility.
Mm-hmm.
So we have viewers who maybe their loved one is in a skilled facility, or maybe they may have to go into a skilled facility and they don't know what to expect. So
Mm-hmm.
from your perspective, can you walk us through your role day to day and what people often misunderstand about what social workers actually do in a skilled setting or rehab setting, inpatient rehab setting?
Yeah, so I think the biggest thing that people think is we're miracle workers, that we can just do anything and everything. Well, you guys are the social worker, you can do it. And I'm just like, well, we're not a realtor. We're not, we're not working in the community. So it's very difficult for us to do all the stuff that is expected. But in the day-to-day world in a skilled nursing facility, we are there from the beginning to end for the discharge planning. And so discharge planning always starts at the beginning. And so we want to focus on what is that plan. And if they're needing a placement, we reach out to someone like you for placement, or, the medical equipment, we order that through their insurance, whatnot. But if it's anything more than that, they're looking to sell their house, to take that money and put it towards assisted living or anything else, we'll guide them to, hey, do you have a realtor? Do you have a notary for your power of attorney paperwork? They want us to sign that kind of stuff. And it's like, we can't. So we have to definitely dig into our resource bag and provide those resources to the patients and the family members. And not only just providing it to them, we're also providing that empathy too. And we're having to be there and be a listening ear, because they're going through so much.
Mhm.
And it's just, I think the main thing that we have to provide in our day-to-day life is just the empathy.
Yeah.
Because that's the most important. If we're providing that, then we're providing the ease and the peace of mind to these patients and their family members.
Absolutely. You touched on something that you said discharge planning should start at upon admission. And I am 1000%. A lot of families don't understand that. They think, oh, my loved one has 100 days to be here. Can you explain what that means and why it doesn't mean what they think it means?
Yeah, so just because a patient is allotted 100 days through the Medicare does not mean that is something that they will absolutely have and it will be used. typically in a skilled nursing facility setting, if 100 days are used, it's not a good sign, because that means they need long-term care.
Mhm.
They need more than just a skilled setting. So we definitely look at that and definitely have to explain to them that just because they are provided 100 days does not guarantee it's being used. And so we have to have that conversation. It should be happening prior to admission, but a lot of times as social workers, we do have that conversation upon admission with them and what that looks like. And so knowing the discharge plan at the beginning is so crucial. It's just like everyone's setting goals in your life, right? We all set goals in our life. We all setting goals where we want to achieve XYZ by a year from now or in 3 months from now. And so if we are knowing what that goal is for that patient, whether it's to return back home, then we know what level they need to be at. They have 3 steps that they have to step into the home, uh, get into their home. So we have to work through that. If we don't know that goal, then there's no way that we can get them to where they need to be.
Right.
So that discharge plan is so crucial and so important. And for me, when I see the higher complex cases, I like to have a plan B,
Yeah.
because it's not always guaranteed that a plan A is going to happen.
Absolutely. And like, okay, so families got, like you said, so there's 100 days, but it doesn't mean you're going to get the 100 days.
Mhm.
Like Medicare or whatever insurance provider can give you that 48 hours, you're going to be cut, like you're
Yeah.
done. And families, I'm sure, come to you like, what do I do now? When you have been
Mhm.
telling them upon admission the plan, they should be listening to you and understanding that plan. A lot of people wait until that last, when you're like, I've been scratching my head, pulling my hair out,
Uh-huh.
screaming at you till I'm red in the face, to help you to understand that, hey, mom and dad aren't going to stay here long term unless they have to, right? But their
Mhm.
plan isn't to stay here long term. There is a goal.
Mhm.
Is that goal? And it's not to just leave them here until that 100-day comes, because it could be, you can get cut in 2 weeks, you can get cut
Mhm.
in 40 days, 60 days. And not to mention, you don't want to use the entire 100 days.
You
And
don't.
can you tell us why?
Yeah, you don't, because anything can happen. Mom can go home. Mom can trip and fall, and it was unexpected, end up back in the hospital, and it's now a broken hip versus just a bruised elbow, or whatever the case is. And then now she needs to go back to a skilled nursing facility. So if all those 100 days are utilized and that fall happens within 90 days, you're SOL. You're out of luck, because now she cannot go back into a skilled nursing facility unless it's private pay.
Yeah. How
So
much
it's
private pay?
so, yeah, yeah.
That's outrageous.
It's very, I don't expect anyone, whenever I mention private pay, they're just like, I don't have that. I'm like, I don't expect anyone to pay it,
Yeah.
but those are the options. And so, yeah, it's so important, as much as like, oh, I want mom to stay there so I can plan, and the family said it might be more like it's more for my benefit than mom's benefit or dad, the family member's benefit. And they don't really want to say it out loud. But at the same time, it's not that we are kicking the person out, because I hear that term a lot. You're kicking them out. And it's not really kicking them out. It's we're looking at the whole picture here. We don't want to use all their days because it's not beneficial to them.
Mhm.
And again, they've met their goal. So now it's ready, it's time for them to go home and
You
live
want them to
their
go.
day to day. Yeah, you want them to. You don't want to keep them.
Yes,
So,
you don't want to be there. Like, you
yeah.
want to go home.
Exactly. So it's the whole picture that we're looking at from the beginning to end. We're not, we don't like to keep tunnel vision. We want to look at everything in such a broad aspect and try to explain it to the patient and the family in a way that they would understand. Because insurance can be very, very overwhelming and confusing.
Very, very much so. We get those calls or those conversations, or like, can you help us? And I'm like, you need to speak with your social worker. And there's a
Mhm.
reason why she gave you my number upon admission, because,
Mhm.
she gave me their phone number and I'm like, oh, they just got there. I'm like, but you need to start touring and
Mhm.
visiting facilities and planning, can they go home or can they not go home? And let's look at plan B. Well, they're in plan A right now, getting the skills and meeting their goals or trying to achieve those goals, but we need to have a plan, because if going home is not an option, let's
Mhm.
start that mission to find the plan B. What would you say are the biggest challenges families face when a loved one transitions into a skilled facility, and how do you help them guide through that?
Mm. I would say the hardest thing is the life transition.
Mhm.
It is something that no one speaks of, and it's a type of grief.
Mhm.
That's what it is. It's a grief that no one speaks of. And it's not you're physically losing somebody, right? No one's passed away, no one's died, but you're losing a sense of independency. And
Absolutely.
when someone loses a sense of independency, their world has changed.
Yeah.
It's changed so much. So when you have your loved one who's been home and they've been doing the yard work and cooking and doing all this stuff, and then all of a sudden they end up in the hospital, they're going to a skilled nursing facility, and now they're in the bed, they can't get up without permission. They can't go to the bathroom without permission. They can't, do all this stuff that they're used to.
Yeah.
There's irritability, there's depression, there's anxiety, there's demands of I want to go home. This is not right. So that is such a hard thing for people to really grasp and understand, that this is a transition. And it's not just for the patient themselves, it's for the family too.
Mhm.
That's a transition where they may now go from a child role to a parent role because their mom or dad has dementia, and
Right.
now it's kind of changed for them, and they're not really understanding that transition.
Yes.
And so everything happens so fast in a hospital setting. You're in the hospital, you're getting the diagnosis, you're getting all the test results, you're all this stuff. And now the case manager walks in. Okay, mom needs to go to a skilled nursing facility. What? You're discharging in 2 days.
Mhm.
Wait, what? You're telling me I've got to go find a nursing home in 48 hours. And so I've got to now take off to work. I got to go tour, or I got to make phone calls. I can't take off work. So
Mhm.
it's so overwhelming. And so I personally, and whenever I've had I have a team beside me, and it's so important to make sure that they understand that we're educating and providing that empathy to the family members, that this is a transition. And
Mhm.
so we just need to be the peace for them,
Yeah.
and provide that okay, let's take this one step at a time,
Mhm.
providing them the resources. So it's honestly, life transition is such a
Mhm.
difficult thing. And I think if family members are provided that knowledge, because it's not
Right.
provided to them. And
People
if
just
it's
think they don't
provided to them, yeah, they can understand, okay, yeah, perhaps I need to write these steps down and just do one thing at a time.
Yeah.
And then it'll be less overwhelming, and
Mhm.
they might be able to have a better understanding of the situation as
Yeah.
well.
Yeah. Okay. That makes a lot of sense. There's a lot going on. Like you said, there's a
Hmm.
lot going on. They don't understand any of the terms that we use, the
Yeah.
acronyms that we use. We're speaking as if they understand.
Hmm.
Um, and going back to discharge planning should begin upon admission. Can you explain the importance for a family member to understand this?
Yeah. So it's so important, because having that discharge plan upon admission, it's about meeting their goals. We
Mhm.
always want to start where the patient is at.
Yeah.
If a
What
patient's
mom
unable to
fell and
walk,
broke their hip?
yeah,
What is
such a
their
common
goal?
one, right?
Yes, like,
So
let's get them out of bed, let's get them back. Yeah.
yeah, so mom fell, broke her hip. What's the protocol? It's typically non-weight bearing for what, 6 weeks or something like that, 4 6 weeks, I think. I'm sure a doctor will listen to this and say that's incorrect, but I
Give or
want to say
take.
it's typically like that, right? So the goal's not going to say, all right, let's get mom up and walking 10 feet, right?
Right.
Because that's not the reality. That's set up for failure.
Mhm.
So we want to say, okay, the goal right now is to do, sit to bed. So sit on the edge of the bed. Sorry, sit on the edge of bed. So let's sit up. Let's get to the edge of the bed. That's going to be the first goal. So it's important to set those little goals for discharge, and what's that going to look like? Was mom independent prior, or was she dependent? Was she depending on things? So we want to make sure that we're meeting those goals and understanding that discharge plan. Say she was at an assisted living facility and now she's unable to stand and pivot,
Right.
because she needs to stand and pivot in order to get in, not use a Hoyer, not use a stair steady.
Mhm.
So now we're coming up to discharge. We have a week left and mom's still not standing and pivoting. Well, what's that discharge goal? Like we talked about this, say 30 days prior. And we talked about, if mom can't stand and pivot, what is the second goal, or the second discharge plan? What does
Mhm.
that goal look like now? It looks like long-term care, or mom's going to have to come home with me and live with me long-term, whatever the case is.
Mhm.
So that's why it's so important, because there's so many different things, and every person is different.
Yeah.
So understanding that discharge goal at the beginning is because we want to set them up for success
Right.
for this transition in their life.
Mm-hmm.
Or sometimes it was a fall and they hurt their knee and they had surgery, and it's a younger person. It's someone who's young and independent, perhaps still working full-time, part-time. It may be easier for them.
Right.
But of course, we're working with the geriatric population that's older, more vulnerable. And so we want to set them up for success. And that's what I always tell the family members, is that we're not discharging them now, but discharge does start now.
Exactly. Like
And
start the
because we
plan,
want to
start the
set them up for success. Yeah.
Absolutely.
Yeah.
And when I get family members like, the case manager gave me, I have 2 days, and I'm like, okay, I've heard your name like a month or 2 months
Mm-hmm.
ago. They told me that you would be contacting me. So I know that the social worker gave you like that upon admission talk.
Mm-hmm.
But I guess like sometimes families are just overwhelmed with what is all going on, or they're working, they have their day-to-day lives, but it like
Mm-hmm.
back, and I'm stressing again, discharge planning starts upon admission. Start
Yeah.
with the social worker upon admission. Don't wait. You never know when you're going to get that 48-hour
You
notice
never know.
from
And you say, oh, we
Medicare.
got days. We don't know when discharge is. We'll put it on the back burner for now. I'll call Veronica later.
Yeah,
It'll happen later. It's fine. I heard she's great. Whatever the case
right,
is.
right.
And then it's right around the corner and it's like, oh
Or we
crap.
get a lot of times, because families will get the call, if they do call us, or if I call them,
Mm-hmm.
a lot of them say, oh no, my mom needs skilled, and she needs a long-term care place. Like long-term care, everything is always long-term care. They
Mm-hmm.
always think that they can just stay long-term.
Yeah.
And they need to know that it doesn't work that way, right? You can't
Yeah.
always stay long-term. So
Mm-hmm.
to have that plan, you can if you need to, and if there's bed availability, or if they can find another facility, it's not always the one you want, or it may not
Mm-hmm.
be near home, but work with your social worker to start having those conversations. Very, very important.
Absolutely.
What's one piece of advice you wish every family knew before they ever needed, like from hospital to skilled nursing? What's one piece of advice?
Know your options. Know your options.
Yeah.
It is just know what the options are. And one great resource to use is Medicare.gov.
Yes.
That is a great resource to use. Medicare.gov. It will give you the ratings, especially for those who live out of state that can't get to Florida, can't get to their loved ones. They can, or a different state. It doesn't matter. Medicare.gov is nationwide, and so you can put in the zip code, you can put in the city. You can find skilled nursing facilities based off of their ratings.
Absolutely.
Now, I also always tell people, because they'll always want to know my suggestion, what's your favorite nursing facility? Where would you want your loved one to go?
Yeah.
I never tell them
Yes,
because my
Medicare.gov.
opinion is always going to be different than someone else's. And so I always tell them, someone's 5-star can be someone's 1-star. Someone's 1-star can be someone's 5-star. But do not let the beauty of a building be the decision why you put a patient in that facility. Please do not let that be a decision.
Yeah.
Do the research. I always tell them to please do the research. I always tell them if they have time to tour the facilities, because I guarantee you, you can walk into a facility and you go, oh my God, this is so old. It is not updated. But you're walking by the CNA who goes, hi, how are you? You're walking by the nurse that says, hey, how are you? Are you here for a loved one? Oh, no, I'm here for a tour. Oh, okay, I can guide you in the right direction, or whatever it is. You're going to meet those smiling faces. You're going to look at the residents who are in their wheelchairs or going up and down for therapy, whatever the case is, and they're smiling.
Mhm.
Or are they sad? Use the observation during that tour to see how everyone's interacting with the patients or within themselves, with coworkers. It's so important. And just having that knowledge can help you. And it's a peace of mind too, knowing that you're putting your family there.
Yeah.
And also understanding the difference between an inpatient rehab, a skilled nursing facility.
Next
Can
question.
my loved one really go home, or do they have to go to a skilled nursing facility?
Mhm.
Do I have that option of them going home with home health care? Do they have Medicaid?
Right.
Do they qualify for home health aid through their Medicaid product?
Mhm.
All those things is just so important to know before they ever need anything.
Absolutely.
And you want to set your loved one up for success and not for failure.
Mhm.
And so, knowing the options that are there is crucial and important, because sometimes someone just needs inpatient rehab, which is it's what I work in right now. So it's a very quick, fast-paced therapy. It's 15 hours of therapy a week. You get typically 3 hours of therapy a day, 5 days a week. And sometimes you just need it for 10, 12 days and then you get to go home. Or sometimes you have to go to a skilled nursing facility at that point because you just need more rehab prior to going back home or assisted living. So knowing options.
What is the main difference? Like, you get the 15 hours a week in an inpatient rehab.
Mhm.
What is the main difference between skilled nursing and inpatient rehab? And why should families consider asking their hospital case managers about inpatient rehab?
Very important. So skilled nursing facility is a lower level of therapy than inpatient rehab. So at a skilled nursing facility, we talked about the 100 days. So you're allotted 100 days. That's what you have going into the skilled nursing. During that time, you have therapy. You have all 3 disciplines, PT, OT, ST. And depending on what disciplines you need, you typically have about 45 minutes to each discipline. And it's 5 days a week, depending on what insurance you have as well. And so it's a slower pace. You're in the skilled nursing facility a lot longer than you would an inpatient rehab. Skilled nursing typically was more vulnerable patients, where they cannot provide that 15 hours a week of therapy.
Mhm.
So that's the difference, where inpatient rehab is the length of stay is typically 10 to 12 days. And then you get to go discharge to whatever the plan is.
Mhm.
So that's the difference between the two.
And like
And it's
inpatient rehab, they don't have to come from the hospital. They can
no.
from
Yeah.
home.
Okay. So yeah, sorry, I didn't hit the insurance part too. Thank you.
Nope.
So yeah, with the inpatient rehab, you don't have to come straight from the hospital. You don't have to have that 3 midnight stay like you do have to have a skilled nursing. So we can admit people from home. We admit people from an assisted living facility. We've admitted people from a skilled nursing facility, actually, where they've been there for 100 days and they can't go home. They just need aggressive therapy to get to an assisted living facility. And we've done that. I have an amazing team that works very, very hard. And the magic that the whole entire team has done for patients is phenomenal. So I've seen that where they walk in, they've used 100 days and we're just like, and they're expected to go to an assisted living. We're like, okay, let's do it.
Yeah. Yeah.
So, and that's the power of inpatient rehab, is because we're such an intensive therapy program.
So I didn't know that. So like, okay, so
Yeah.
they use their 100 days. So they can't go back into skilled nursing, right, for 60 days because then it re-ups. But
Correct.
they can go into inpatient rehab after they use their 100
They
days?
can. Yeah.
Oh,
Yeah,
very
they
good
can.
to
Yeah.
know.
So we're considered hospital days.
Oh,
So we're billed under hospital days. I say we, inpatient rehab. Inpatient rehab is billed under hospital days, whereas skilled nursing is billed under the Medicare 100
that's
days.
good to
Yeah.
know. Thanks for
Yeah.
telling me that. Okay.
Yeah.
Very,
Yep.
very helpful information. All of this is very helpful. And I know it's like a maze, right? We're
Mm.
involved in this web. And even for us, sometimes we're scratching our head,
Mhm.
new regs and policies, or there's just change in how things are managed in our industry. But for families, it's like a whole new language. It's like learning a whole new language with a different dialect. And
Yeah.
it's very foreign. So this is very helpful information. I would love to have you back as a guest
Yeah.
to continue helping our families, because like you said, a lot of families, I mean, this is just the icing, the very
This is,
barely
oh
touching
God. Yeah. This
everything.
is literally the icing,
Yeah,
because
we're like
there's
talking
so
in layman's
much.
terms. Yeah.
Yeah. Yeah. There's so much. And it's so important too, is like, if a family member or patient's getting a case manager that's using a lot of acronyms or using a lot of terms that they don't understand, it's so important for the family to advocate for themselves and say, I'm sorry,
What is
but
that?
break this down for me. Like, I don't understand what you're saying.
Yeah.
And that's one thing, whenever being a leader, is I've told my teams is that making sure that we're definitely putting this into layman terms. Like these families don't understand it. And we're throwing out, oh, HHC, IRF,
Mhm.
SNF,
Yeah.
ALF, DME, all these little terms that we're
Yes.
so used to saying. It's like, huh?
Yeah.
But if you
For
say
real.
medical equipment, they understand medical equipment.
Uh-huh.
You say home health care, they understand home health care. Explaining the home health care versus home health aid, that's a
Yes.
different story.
That's a whole other topic,
So
which
yeah.
we should come back and speak about. All
So
the
yeah,
acronyms. Yes, yes, for sure.
it's just it's very important that we're being that resource for the family.
I have a funny story
So
about acronyms. I had a gentleman that was like, I have been told to speak to Ed. And ever since I was admitted to this place, and they keep telling me there's no Ed and blah, blah, blah. And I'm like, Ed, okay. So I contacted the social worker. She's like, we don't have Ed. Ended up being executive director. It was the acronym. I'm like, oh my gosh. So that is one. Yeah. And it was spelled out when I read the document. I'm like, well, who told you to speak to Ed? Oh, I have it here in the admissions. Ed is ED, meaning executive director. And I'm like, oh, okay. Yeah. So
yep.
even in the paperwork, don't use acronyms.
Yeah.
Think of it as from what a patient or
Mhm.
family, they don't understand our
They
language.
don't. No.
It is a
No.
different language.
Yep. Yep. Like I have my own resources, it's the list of home health aides or list of different things. And I always spell it out because
Yes.
you're always, they don't know what they don't know.
Yeah.
It's just like if we were to enter their world of accounting or something like that, and we're like, all these
I
numbers,
would not know
Yeah,
anything
I
about
wouldn't know
accounting.
what they're talking about.
This is why you do what you do and we do what we do.
Yes.
Exactly.
So
yeah, for real. Well, I am super grateful to have you here again. As I said, I want to have you back. Maybe we can make this like a rotating thing just to get the
yeah,
information out there for families, because it's very, very important.
absolutely.
And to get them to understand that there is so much that we can answer for you by watching these, podcasts. And if there's anything that they're interested in, they can put it in the comments on our YouTube channel and just let us know what topics that they'd like for us to focus on. Because I think
Absolutely. Yes. Yeah, that'd be wonderful.
Awesome. Well, thank you so much for joining. I appreciate it.
Thank you. Thank you for having me.
Bye.
See ya.